Good day, everybody. Bonjour, здравствуйте. My name is Kabangу Serge Kankolongo. I'm a fifth year medical student, Group 44, and I am from Saratov State Medical University, and I am presenting to you a topic on dermatology titled Molluscum Contagiosum in Immunodeficient Patients. There are several diseases that cause immunodeficiency. Firstly, HIV and AIDS. Second disease is immunocompromised. Lesions are especially common and extensive on the face and the neck. And other diseases that cause immunodeficiency are sarcoidosis, lymphocytic leukemia, congenital immunodeficiency, selective immunoglobulin M deficiency, thymoma, treatment with prednisone and methotrexate, disseminated malignancies, refractory atopic dermatitis. Now we are focusing on HIV and AIDS. Molluscum contagiosum is a common self-limited cutaneous infection in immunocompetent individuals. However, in immunocompromised individuals, the infection often has a atypical presentation and can be difficult to eradicate, making both the diagnosis and treatment challenging. Due to the advancement in the management of patients with human immunodeficiency virus and cancer, there is a growing population of immunosuppressed individuals, signaling the need for dermatologists to recognize and manage related skin diseases. Patients with HIV infection generally have more widespread lesions. Why is this so important? We are in a growing population of immunosuppressed patients. It is important to recognize Molluscum contagiosum as a potential indicator of underlying immunosuppression. Testing for HIV should be offered to any patient starting immunosuppressive therapy, such as biologic agents. Transmission and clinical manifestations. Lesions in adults are most often sexually transmitted and are located on the genitals, suprapubic area, and or inner thighs. Lesions may also occur in the skin folds, involvement of the face, or giant lesions more than 1 centimeter may occur in immunocompromised patients. Immunocompromised patients may have lesions that persist for years or indefinitely and are refractory of treatment. Other locations of clinical manifestations. Molluscum contagiosum has a wide range of atypical clinical presentations in patients with AIDS that can make it difficult to diagnose. Complicated cases of eyelid Molluscum contagiosum have been reported in advanced HIV in both adults and children, resulting in obstruction of vision due to the large lesions up to 2 centimeters or hundreds of confluent lesions. Molluscum contagiosum is a common skin infection. Among patients with HIV and other types of impaired cellular immunity, the prevalence of Molluscum contagiosum is estimated to be as high as 20%. The Molluscum contagiosum pox virus survives and proliferates within the epidermis by interfering with tumor necrosis factor, TNF, induced apoptosis of virally infected cells. Therefore, intact cell-mediated immunity is an important component of prevention and clearance of pox virus infections. In immunocompromised patients, the presentation of Molluscum contagiosum varies widely, and the disease is often difficult to eradicate. This review will highlight the prevalence, presentation, and treatment Molluscum contagiosum in HIV-positive patients was first recognized in 1983, and its prevalence is estimated to range from 5% to 18% in HIV patients. Molluscum contagiosum is a clinical sign of HIV progression, and its incidence appears to increase with reduced immune function, that is, a CD4 cell count less than 200 millimeter. How did the patient develop molluscum? What was the primary source from which the infection spread? Notably, molluscum is acquired from skin-to-skin spread, which includes sexual transmission, casual contact, auto-inoculation, that is the Cobne phenomenon, and which individuals are of a greater risk of developing molluscum. Molluscum mostly commonly affects sexually active adults, patients with impaired cellular immunity, and children. It occurs most commonly in individuals aged between 15 and 29 years. There are no reports of zoonotic transmission. There are other diseases that can mimic molluscum, hence need to do differential diagnosis. Other diseases includes which have individualized localized lesions, especially in the genital areas, are verruca, benign acnasal tumors like syringomas. We also have pyodema or condyloma. They mimic disseminated deep fungal infections such as cryptococcus, penicilliosis, and histoplasmosis. Giant lesions of molluscum may mimic a cutaneous malignancy, such as a basal cell carcinoma or keratoacanthoma or an epidermal cyst. Disseminated cutaneous histoplasmosis on the forehead, manifesting as varicose papules and plaques. What laboratory studies should you order, and what should you expect to find? Laboratory studies are not typically helpful in making this diagnosis. If the diagnosis needs to be confirmed with testing, a skin biopsy or histologic analysis may be helpful. Imaging studies are not helpful. It is important to ask about contacts with similar lesions and sexual history. If lesions are only present locally, they are easier to manage, as topical and local distractive methods are often more effective in these cases. What are the complications that can arise? Molluscum itself does not typically lead to complications, but lesions may become widespread and psychologically devastating, especially in immunocompromised patients. Lesions are highly infectious since it is caused by a virus, pox virus, and may be passed from person to person. But the prognosis for molluscum infection is good. What are the management? The management of Molluscum contagiosum in patients with HIV and AIDS is difficult. Molluscum contagiosum has shown no evidence of spontaneous resolution in patients with HIV, and treatment with one modality is often insufficient. Successful when a combination approach is utilized with destructive measures. Now, what are the treatments to use? We have several treatment options. These treatment options include topical therapies like topical acids, podophylotoxin, candaridin, imiquimod, tretinoin, adapalene, and topical cidofovir. Physical destructive methods are also helpful, and these include curettage, pulsed dye laser, cryotherapy, and photodynamic therapy. Systemic therapy is also for HIV patients. Numerous reports have described successful treatment of disseminated or recalcitrant Molluscum Contagiosum with topical imiquimod. Cidofovir, an antiviral used to treat cytomegalovirus retinitis in patients with HIV, is a promising antiviral agent against the pox virus family. However, the use of cidofovir is limited by its high cost, especially when compounded into topical formulation. What's the best approach in relation to HIV? From a systemic standpoint, numerous reports have shown that treating the underlying HIV by optimizing highly active antiretroviral therapy, lesions after beginning HAT, the lesions spontaneously resolve with the progression of immune reconstitution. How can we prevent this? Molluscum can be prevented by avoiding skin-to-skin contact with infected individuals. Special cases, malignancies. Patients with hematologic malignancies like lymphoma, leukemia, they comprise dermatologic conditions like varicella, herpes simplex, papillomas, perioderma, and cutaneous cryptococcis, as well as Molluscum contagiosum. Similar to HIV-positive patients, the lesions of molluscum described in patients with malignancies do not tend to spontaneously resolve, requiring biopsy for definitive diagnosis. Only partial resolution was achieved with cryotherapy and casting of the lesion in an attempt to slow the progression. Other special cases are transplant patients and nodular basal cell carcinomas. The standard treatment are identical to those used in patients with HIV, including ablative methods via liquid nitrogen, electrocautery, cantadrine, trichloroacetic acid, and topical retinoids. Immunosuppression through the use of steroids, chemotherapeutic agents, and biologic drugs often is the result of treatment of various diseases. In patients with psoriasis, treated with systemic immunosuppressive agents, methotrexate, cyclosporine, and biologics. There are other skin disorders treated with immunosuppressive agents that also have been associated with Molluscum contagiosum. In a patient with pemphigus vulgaris treated with prednisolone, pimecrolimus, and azathioprine, Molluscum contagiosum lesions were observed on the face and within healed pemphigus vulgaris sites. Spasiba za vнимание. Thank you for your attention. Merci beaucoup pour votre attention. I've come to the end of the presentation. The rest are the references